Hello, good afternoon, everyone. Nice to see you all today. My name is Alice Nelsner, and I'm the CEO of Inland Wellness Information Network, as well as the San Bernardino County Medical Society. And we're super excited to be offering the fourth in our series of Food, Health, and Cultura Latinx discussions. Today's session is proper nutrition before and during pregnancy and in early childhood. And we are thrilled with our lineup of very talented and accomplished presenters today. I'm going to introduce them in order of their presentations, and then we'll have them go ahead and take the floor. So first, we are very excited to welcome back Dr. Antonio Miranda, RD, PhD, LD, and CD, CES with Antonio Nutrition, LLC. Really quickly, I just want to mention something very exciting. Dr. Antonio Miranda has had his first book, I think it's your first book, right? First book published, Diary of a First Generation College Student, Part 1, Stories and Steps Towards Your College Success. And this book is on pre-sale now at Amazon.com in paperback and ebook. Sorry, I'll get that right. It's fully available on July 29th, but it's really an exciting story of a first generation college student's experiences, offering practical college and life advice through real stories of struggle and success. And we really want you to all take a look at that. And he may talk more about that, I'm not sure. So thanks, Dr. Miranda. Next up, we have Erica Montes, MD, FACOG, obstetrician and gynecologist with Honor Health. And it's really an honor to welcome Dr. Montes. And then we have Emma Oliveira, MD, FAAP, pediatrician, assistant clinical professor at University of Illinois at Chicago College of Medicine. And again, Dr. Oliveira is an expert in her field, so we're really thrilled to have her lend her expertise with us today. And finally, we have Dr. Elon Shapiro, MD, pediatrician and medical director for health and wellness at Altamed, and he'll be joining us shortly as well. So we are going to send it on over to Dr. Antonio Miranda. Take it away, Dr. Miranda.
Thank you. Next slide, please. So and thank you for introducing my book. What I usually say is I poured my soul into this book. It's called Diary of a First Generation College Student, but it's not a diary per se about me, but I wrote it because all of us what I write in the book is we're all first gens at something. Many of us are first gen to go to college. Many of us are first gen PhDs, MDs. So we're all first gen at something, and it's very important that we honor the sacrifice of the people that laid the path, such as my parents that came from Mexico. But especially a major theme of these presentations is how can we help the next generation? If we're going to really improve diversity and inclusion in the next generation and have more Latinos working, well, we need them to understand the culture, right? So the book is a little attempt at that. But anyways, back to today's topic, and I put the book in the chat if anybody is interested in looking. So for today, the beauty is that as Latinos, we're called to have some ánimo, and I want to recap our sessions that we've had so far, sessions 1 through 3. The overarching summary would be, we brought to the table a lot of experts, and I'm humbled to be among so many experts today and experts in the previous talks. And we encourage all of you to go to the website. If y'all would like to add the website in the link so that they can see the previous recordings, because those links and the CMEs you get from them are really about the cultural humility that we all bring to the table. As Mexicanos, as Peruvians, as Cubanos, we're very heterogeneous as Hispanics. And so we bring in our expertise with our different populations, but with our different culturas. And the second thing I'll say is we inject our ánimo and we bring in this cultural camaraderie to where together, how can we talk about these data? How can we talk about patients so that we can help the patients that we're serving today? So as a recap, session 1 looked over health misconceptions and also the economy that Latinos hold up in the United States and how it's important to care about our populations. Session 2, diabetes. What are the Hispanic health disparities that are out there, and what are different strategies that all of us in our different areas are doing to help the community? And then, of course, Session 3, lessons from our ancestors. A major theme in all of this is how can we have a return to our cultural origins to promote health behavior among current and future Latinos. So we talk about blue zones, we talk about determinants of health, we talk about a variety of different topics from all of the experts. Next slide, please. And for today, we're just going to continue that with even more experts, proper nutrition before and during pregnancy and in early childhood. And with that, we'll get started with Dr. Erika Montes.
Thanks, Antonio. All right, we can go to the next slide, please. Perfect. All right, well, my training is as an obstetrician and a gynecologist. I've been in private practice for over 12 years now. So I have a pretty good amount of experience, and a large portion of my population is Latinas, and unfortunately, a large portion of those Latinas do have gestational diabetes, which is something we definitely wanted to touch on since we're talking about pregnancy and childhood in this session today. We know that women are usually the healthcare decision makers for the family, and pregnancy is usually the first place where women are seen for any type of healthcare. So for me to be in that position as an obstetrician, it's important for me to be able to give them information regarding the importance of diet and lifestyle. So I did want to talk a little bit about gestational diabetes, and more importantly, in respect to how it affects Latinas. So some statistics that I found from my literature in my American College of Obstetrics and Gynecology were 1 in 4 Latinas will have some form of diabetes, whether it's gestational or overt diabetes. Latinas also have a 50% chance of developing some form of condition regarding diabetes in their lifetimes. And then we know that we are at risk just given our ethnicity, and we are 1.5 times more likely than non-Hispanic white women to die from diabetes. And gestational diabetes disproportionately affect pregnant Latinas, which again, I have seen that clinically in my own practice. And so really the question is how can we keep Latinas healthy? And learning about gestational diabetes is a big part of that. And I've added a picture here on how you can see me delivering a baby. It was a C-section that I did, and I think I've delivered over 3,000 babies so far. Okay, we can go to the next slide. All right, so gestational diabetes. So what is it? There can be some misconceptions that gestational diabetes is due to, just alone, like what people eat and how obese they are, how they're doing as far as their health. But in reality, of course, those are risk factors, but we know that gestational diabetes actually is, because it is occurring during the pregnancy, a lot of it has to do with the placenta. So there are certain hormones that the placenta will release. Usually the ones that we know can make you more insulin resistant are things like estrogen, which of course we know goes up during pregnancy, cortisol, and then there's another hormone called human placental lactogen, which also increases your insulin resistance. So a lot of patients feel bad, and there's even some patients who think I'm so healthy before I got pregnant. I eat right, I exercise, and they're like, why am I a diabetic? And so I have to explain to them that a portion of it is actually just the placenta causing them to have this insulin resistance, and then they're labeled as a gestational diabetic. The American Diabetes Association does recommend screening for those undiagnosed type 2 diabetics at their first prenatal visit, because that can affect the pregnancy as far as risk factors go. And it also can affect what their risk is to eventually become a diabetic after pregnancy. So we definitely always want to screen patients who have certain risk factors early in pregnancy, and then we will screen everyone else between 24 and 28 weeks. That's kind of the gestational age where the placenta starts growing in size. And then that's where we see the release of those hormones, making you more prone to diabetes right before the third trimester. And that was the reason why we chose to screen people between that gestational age. Of course, like I mentioned, risk factors are obesity, a first degree relative with diabetes, a history of pre-diabetes, high risk ethnicity, which of course is Hispanics or Latinas, history of an infant if you've had a baby over 9 pounds, that potentially could mean that you're at risk for diabetes and may have not been caught in your first pregnancy. Polycystic ovarian syndrome, we know that those patients have a higher risk of insulin resistance, so we definitely want to screen them. And then patients who have a history of hypertension or essential hypertension. And then here you can see me, there I am pregnant with my third son. I fortunately did not have gestational diabetes myself, but my mother has diabetes and she has to use insulin. She didn't have diabetes when she was pregnant with myself or my sisters. But I think unfortunately our risk factor is just our high risk ethnicity. Okay, you can go to the next slide. Thank you. All right. So as far as gestational diabetes, I would like to talk a little bit about how does it affect pregnancy, labor and delivery, and then of course the baby. As far as pregnancy goes, we do have to do a lot more testing. There's a lot more visits that we have with those patients, more ultrasounds, non-stress tests, which are tests that we use to make sure that the fetal heart rate tracing is reassuring. And then of course there's risk that we have to take into account during labor and delivery when we deliver these patients. Preeclampsia is a known risk factor for gestational diabetes. I see it more so in those patients that require treatment like oral hypoglycemics or insulin. But definitely preeclampsia or some form of gestational hypertension go hand in hand with diabetes. Usually, of course, there's a higher risk of macrosomia, which is basically a baby who is over 9 pounds, 9 ounces. I think my largest baby that I delivered vaginally was 11.5 pounds. And my largest C-section baby was about 13.5 pounds, and she did have gestational diabetes. So those things are something that just happened because of the high sugar levels that we're seeing. Of course, the baby is bigger if the mom is not as well controlled as we would like them to be, but we still have some pretty good controls. We can check their hemoglobin A1C to make sure that their number readings that they're providing to us are accurate. And I still see big babies because remember, some of it could be constitutional. That mom just has big babies depending on their genetics and things like that. So, macrosomia, though, unfortunately does increase the risk of an operative delivery, which is forceps or using a vacuum. And then, of course, there's a higher risk of a cesarean delivery. We don't recommend, it's not recommended to automatically offer a patient a cesarean delivery just for gestational diabetes. But if we do a screening ultrasound in the third trimester and it does appear that the baby is going to be at least 4,000 grams and for sure 4,500 grams, then a C-section may be indicated. The pediatricians know this. They can see the neonatal hypoglycemia and hyperbilirubinemia with these babies. So that's something that, us making sure as obstetricians we control their sugars as best as possible, especially towards the end of the pregnancy, may help with that. Unfortunately, we have seen stillbirth as a risk factor for gestational diabetes. I thankfully have not really seen it very often, but I do remember seeing it in residency. And it was one of those things where she basically was undiagnosed. She came in, I believe she came from Mexico, and she came to our OB triage. I worked in a county hospital, and she came in like it was like her first visit here with us, and unfortunately the baby was not moving, and she was in her third trimester, and she did have a stillbirth. So that, there's many factors for that, but I think a lot of it is sugar control, and then of course prenatal care. And then as far as the children go, I was reading a little bit, just catching up, refreshing on research. Fetal exposure to maternal diabetes can contribute to childhood and adult onset obesity and diabetes in offspring. So I think we know that health and diet and everything starts in utero. So that's just something to think about, the fact that if your mom had gestational diabetes, that child is at increased risk of obesity and diabetes as well. So much goes on in utero, and that can kind of be a path of how that child's life could develop, or what their health could be like. Okay, we can go to the last slide. Thank you. And then finally, as far as gestational diabetes, how does it affect the mom? So we definitely want to make sure that these women that are diagnosed with gestational diabetes, I didn't get to go over the classes of gestational diabetes, but we consider those to be A1 or A2. A1 is where it's gestational diabetes controlled with diet, and then A2 is gestational diabetes controlled with some type of medication. The oral hypoglycemics are a lot better than if are more utilized at this point. I think back in the day it was a lot of insulin, but if a patient can be controlled with metformin or glyburide, we do tend to try to do that if possible, just because insulin can be a little bit more difficult to get to be able to obtain. And then, patients don't like to poke themselves, but of course, if they need insulin, we convert to that. So we do try to make sure that these women have screening after pregnancy, which is usually a 2-hour glucose tolerance test. And then I always tell patients to make sure that once they see their primary care, if they don't continue to see that obstetrician, to make sure that they tell their physicians that they had a history of gestational diabetes and even preeclampsia, because we know that these two conditions during pregnancy is kind of like, it really truly is a stress test for the future of a woman's health. So if we know that a patient had gestational diabetes or preeclampsia during their pregnancy, that should be a little light should go off for the physician or the provider that's taking care of that patient, because we should be looking and screening them more for these conditions later in life. We also know that 1/3 to 2/3 of individuals who have gestational diabetes in one pregnancy will have it again in a later pregnancy. I think it's more towards 2/3. I have had a patient who had diabetes in the first pregnancy, diet controlled, so an A1 diabetic, second baby didn't have it, and third baby had it. So, there are some factors, but I do feel like if they have it in the first pregnancy, more than likely they'll have it in the second. Of course, weight plays a factor. So just continue to try. I always tell patients, the way you were eating during pregnancy, we want you to try to continue to work on eating and kind of keeping that lifestyle habit if possible, because of your risk of becoming an overt diabetic later in life. And I think patients kind of my pregnant patients get used to eating healthier and kind of counting their carbs and watching what they're eating. So it's not that hard for them to continue to do that. Of course, it can be a little more difficult because they're not pregnant. So it's not on their mind as much. But I always have my patients, especially my Spanish speakers, see a nutritionist who is Spanish speaking, who's available to them, who they can make sure that they can ask questions to. I think that's the most important thing. That way, that Spanish speaker, if they kind of have an idea of what their diet is, they can kind of give them some healthy options with what their diet, what the type of diet they're used to eating, and that seems to work very well. Just a couple last minute statistics. It is estimated that up to 70% of women with gestational diabetes will develop diabetes within 22 to 28 years of pregnancy. I found that statistic on Up to Date on a recent article. And then 60% of Latin American women with gestational diabetes will develop type 2 diabetes within 5 years of their index pregnancy. I have a couple patients I can think of who have now stopped having children, and they are overt diabetics, and they're pretty well controlled on metformin. But I mean, these statistics are real. I think gestational diabetes is one of those conditions that, again, gives us a lot of insight into the future of a woman's health. And we just need to make sure that as if you're a primary care doctor or someone that sees patients for general health, just make sure to ask them about their pregnancy history, because it can make a big difference on kind of what you're looking for and their screening as well. So yeah, I think those were the main points I wanted to cover, and I appreciate it. Thank you for your time. And we'll move on to Dr. Emma Olivera.
Thank you so much, Dr. Montes.
Thank you.
Next slide. So a little bit about me. I'm Bolivian Cuban. I'm from Chicago. I'm very passionate, therefore, on food, my cultura, and as a physician on health. I'm really glad that this talks about the mother, the parent, as well as the child, because as Dr. Montes mentioned, they link together. Next slide. As a parent, the pregnant person is, taking care of themselves, eating, all this is playing a part on the health of the fetus. And so a lot of times when the parent, the pregnant person is, taking care of this, fetus, people are thinking about medications or illicit drugs or the environment, but really we're also thinking about what they're eating as food. And these things that they're eating are also leading to how big the baby is growing, how they're growing, and how they're going to end up. As she mentioned, if the mother has diabetes, this can lead to the baby having an environment that is full of sugar. So when the baby is born, we as pediatricians are also looking to see how the baby's sugar is going to be for the first few hours of life. That baby is used to a high sugar environment, so the sugars actually can be low. And so we have to make sure the baby is eating and, feeding right away, either at the breast or formula, and that's really key. And so we're always thinking as pediatricians, these infant outcomes lead to childhood outcomes, lead to adult outcomes. So prevention is key. When I talk to children and parents about their child's health or about how their weight is doing or how they're growing, I'm always talking about, what I'm doing is going to affect you. Your adult doctor is going to say, what was your pediatrician doing this whole time? What was they telling you? This is how you ended up. Because what we're seeing a lot now is that 30-year-olds are having to be on, blood pressure medication. 20-year-olds are on, cholesterol medications. All these medications are starting early and earlier. And so as pediatricians, as parents, really we have to do a better job at what our children are eating right now in this early childhood period. And so that really is making sure that they're not overeating, that they're listening to their, hunger cues. So many times we tell children, you must eat everything on the plate. And really, you want to make sure that when they're full, they're full. You know, as parents, we're, you know, your job, we always tell as pediatricians, your job is to provide their food, and their job is to decide whether or not to eat it. So many times parents feel bad, you know, that they're forcing the child to eat, and then the child's not eating, and then they go without eating. But no, your job is to provide the food on the table, and their job is to decide how much of it to eat. So that's really key when we're discussing eating, picky eaters, you know, babies who eat so much, you know, these kind of things is really, you know, they should follow their hunger cues, and, you know, because that can lead to excess weight. Next slide. So in the office, we're looking at growth curves, and we're really looking at, when we're looking at the growth curves, how are they following along? If you have a child, you know this very well. Your doctor will show you the growth curves. 50th percentile means average. When you're above the 95th percentile, that means you're over, you know, obese. 98th percentile is obese. And so we're looking at also something called the body mass index. So when we take into account your height and your weight, you know, are you weighing a certain amount because you're very tall? Are you weighing a certain, you know, lower amount because you're short? Are these things matching up? Because sometimes you weigh a lot because you're tall, sometimes you weigh a little because you're short. So BMI takes those things into account and says, okay, these things match up or don't match up. And then we're following along as you grow up. And, you know, after the pandemic, so many kids shot up, and obesity just shot up for everyone, but in particular for Latinos. And now the CDC states that 1 in 5 children in the United States and adolescents are obese. So we really need to take into account this. And when we look at Latinos or Hispanic, our group is really the highest. 26% are obese, and African American or Black are right after us at 24%. So really, we need to take a closer eye. And so many times I see parents, especially my Latino families, who see, you know, their child and say, oh, my child is underweight, you know, and they're looking at the other children around their child. Oh, doctora, my child is so underweight. Look at them. And I look at the growth chart and I say, no, your child is perfect. They're at the 50th percentile for their BMI, the 50th percentile for their weight. They're at a healthy weight. The problem is we're seeing so many children that are obese. So keep doing what you're doing. Do not listen to grandma who's giving them cookies and juices and everything like that to get them to gain weight. You have to let the child listen to their hunger cues, eat what they're eating, you know, because really we're seeing so many children out there that are obese, and your child is actually at a healthy weight. So we're looking at this, and when we're looking at, you know, who in terms of boys, you know, more Latino boys are going to be obese. Almost 30% of Latino boys. When we're thinking about obesity, we're looking at more lower income families are affected. You know, when we see you know, social determinants of health, which Dr. Shapiro will talk more about, really the food deserts and access to, you know, proper nutrition, that can play a big factor in obesity. And so many of our Latino families that work, you know, many hours and come home, they can't give their child proper nutrition. It's like faster to go to McDonald's, give your child the food. And so then, you know, okay, I'm going to give you McDonald's really quick. And so they're getting high cholesterol, increased fatty liver. I see so many children in my office who has increased liver enzymes, which leads to later on in life having, again, issues with their liver enzymes, issues with their cholesterol, need for medications. Now we're talking about starting blood pressure medicines. And so when we're looking at these things in the office, it's hard to discuss weight with a child. So what I always tell the child is, Mira, we are like a car. You are a brand new Porsche, a brand new Corvette. You are just out of the dealership. And what are we doing? Are we putting in good gas? Are we doing the pristine gas? Or are we putting the cheap gas in? What happens when we put bad gas in a car that's brand new? Does it run fast or does it run slow? They say, slow, doctora. I go, yeah. Do you want to run fast? Yes, I want to run fast. I go, yes, exactly. What about if we put so many things in the trunk, like we're moving, and we put our bicycle in the trunk, we put our toys in the back of the trunk, we put our dirty shoes, all the things in the trunk. Does the wheels go fast or slow? Are they all sunk down or are they full? They say, no, it goes slow. So does the car, run like all around the block? They say, no. Just like you, if you put on weight, you're not going to run as fast as your friends at school. Oh yeah, you're right. You're right. Okay, so then they get it. But I go, does the car still look like a brand new Porsche? Is the paint brand new? Does it still look good? Yes. But we're not talking about how you look. We're talking about if you're using good gas, if you're putting too much in the car, and then I go, doctors are like mechanics. We could put a new engine in a car. We could put like if your knees are bad, we could give you new knees, just like they can give you new tires. We could do all of that. I want to prevent you needing new knees when you're 40. I want you to run fast. And I also, tell them that, I want you to be a shiny new car till you're 100 and not need to go to the mechanic so often. I want you to be running fast, going fast. And the other thing I tell them is activity. It's so important. Do you think if you leave a car in the parking lot for the whole summer or the whole winter and you turn on the engine, is it going to turn on or is it going to go? And they say, oh no, I think it's going to have a hard time turning on. I go, the same thing happens to us. We start sweating, we start feeling sick, we throw up. We can't run like the rest of our friends who run every day. The same thing, we have to take our cars out of the lot. And so I want you to go take your car out on the lot. And I tell the parents, they have to take themselves out on the lot too, because we are like the cars. If we do not get moving and we do not put good gas in our cars, and we put too much weight in our vehicles, we're going to need new parts, we're going to need to go to the mechanic too much, and we're going to be too bad. But our car is still going to look brand new. I had a Corvette that I had to put in the junkyard that looked so great because it never was run. So I tell these to the kids and they feel good about themselves, but they say, look, Dora, I'm going to eat healthier. I'm going to do these things. So that's what I try to do when I'm focusing on this growth curve. And I also say, you're young, you're going to grow taller. Let's make small changes so you grow taller and you just go over to this other line on the growth chart. Let's focus on you leveling out so that we don't have to lose weight. We just have to stay the same. Can we maintain weight? Let's focus on maintaining weight. That's the most important thing, because so many times people, I feel like adults in particular, we're like, I gotta lose 50 pounds. And that's not reasonable, especially for a kid. How about we maintain weight, we do healthy lifestyle changes, and we kind of go to the next line. We go from red to yellow to green, and that's all within the next few years. and then that's better. So we go from obese to overweight to healthy. So that's what we really want to focus on when we're talking about healthy lifestyle changes, doing better gas, taking out the weight from our car, and taking our car out for a ride. Next slide. As I mentioned, you know, so much of what our children eat can be related to our environment, how our parents are working, if they're working in a, you know, low income jobs, you know, in a low income area. And so it's important for us, especially in healthcare, to ask about hunger vital signs. This is a new thing. And so you can ask questions, and the response could be often true, sometimes true, never true. In the past 12 months, one question is, we or I worried whether our food would run out before we or I got money to buy more. 2, the food we or I bought just didn't last and we or I didn't have money to get more. So these are important things to find out, because as physicians, healthcare providers, sometimes we know about food pantries in the area, or we know a social worker who can tap into the family into these resources, or you know, like an OB-GYN or a pediatrician, there's a program called WIC. So I'd like to take a moment to talk about WIC. Next slide. So WIC is called Women, Infant, and Children. So among WIC participants, you know, age 2 to 4 years, there's data that shows that obesity can decrease. And so there is a prevalence in obesity, and there's 12% in 2-year-olds, 15% in 3-year-olds, 16% in 4-year-olds. And this prevalence is present in both boys and girls, but this has decreased in the past, you know, past 10 years from 15% to 14%. And in what they've also noticed is that breastfeeding is also a marker of prevention in obesity. So people who were in a WIC program that were in an exclusive breastfeeding package were also noted to have less markers of obesity in the first 3 years of life. So it is important to, you know, for families who are of a lower income to be tapped into WIC resources. They provide formula, food, and healthier options for families. So if a woman or a pregnant person is able to receive WIC, you know, as an OB-GYN, you know, they should allow, give them information on WIC. And then pediatricians, we also let them know about WIC, because this can be a way that if those food hunger vital signs, you know, show that there is some inability to get formula or other food items, we can tap them into those resources. And it has been shown to decrease some subgroups of, you know, hunger as well as obesity. And I'm going to now pass the baton to my colleague and pediatrician, Dr. Shapiro.
Doctor, it's always a pleasure to be with you and to be part of this amazing conversation.
Hey, Dr. Shapiro. Dr. Shapiro,
yes.
you've got some feedback going on. I think you're on 2 sound systems.
I would love to tell you this for 1 second. Let's change this. Give me 1 second. Let's do troubleshooting online. We have yes, we do have something, and looking more professional for everybody. And here we go. Can you hear me now? Can you hear me?
Perfect. Beautiful.
Perfect. Then it's always good to have emergency microphones just laying around. Thank you, everybody. Then I was saying, Dr. Olivera, thank you so much for that introduction and all the powerful things that you were saying. A lot of the times when we are starting to do all these things with our community, especially with our kids, we're thinking about so many things. Next slide, please. One of the important things that we have is that every time that we're talking with our kids and the way that we were brought, we see everything like, the beautiful green stuff that we have on one side, or on the other side, all that dry stuff that we have on the other side. And we rarely see everything with colors. We tend to say all the bad food or all the good food, and we need to start changing that. The same way that we have heard from the importance of preventing the load of maternal diabetes. The same way that we need to start thinking of us as parents and family members, how can we improve and create these conversations? Because it's not about white and black. It's not about the green side or the other side. It's about life. It's about wellness. It's about how are we really perceiving absolutely everything that we're doing. And let me tell you why. I don't know about you, but you have seen that technology is advancing and we're seeing all these amazing pills and technology. But the things that we're talking right now have been there for centuries. And let me tell you a little bit more about that part. Next slide, please. At the moment that we start that conversation with all our patients, and I have been a patient, I am a patient, and one of the most important conversations that we have with our patients is, make sure that you have your vaccines, make sure that you have all of these things. But there's a couple of things that we end up connecting. Next, please. At the moment that we have that conversation with our doctors, there's common things. And sometimes we tell everybody, like, make sure that you're eating healthy. Make sure that you eat the green stuff. And of course, the family members that I take care of, they know what's the green stuff. They know about the fruits. They know about the important thing that, eating low your caloric intake, not drinking sodas. They know about it. Also, you will hear me say, and probably Dr. Olivera is the same thing, and Dr. Montes for sure, we tell you, please make sure that you're doing sports. Go out there and do sports. But family, next please. What ends up happening when we actually walk out of the clinics? Is there a safe green space? Because Dr. Shapiro told me to do sports, right? Is there a green space? Is it safe? Or the same thing that we go to a supermarket. Do we know specifically where are those green stuff, those things with colors called vegetables and fruits? Do we know how to cook them? Do we have enough resources to actually buy them? Then we have as parents a lot of questions on top of our minds. And most importantly, we do not know a lot of the times how to address those. That's why it's so important having this type of conversations, because right now, with the conversation on this specific series of conversations with Food, Health, and Cultura, you will find that it's not necessarily more expensive. It's not necessarily that I need a beautiful green field out there. It really means that we have the opportunity to do a couple of things and not just look at the weight part of it, but change the conversation to make sure that we're talking about wellness. And I was actually impressed about el cochecito that we were talking about, the carrito that we need to be taking care of. And I'm 21 years old, and I do want to make sure that my knees continue to work the rest of my life to make sure that I'm running with my kids. Then that's the philosophy that we need to be having right now. And I'm going to share with you a couple of things. The first one, it's La Dieta del Dr. Shapiro, Dr. Shapiro's diet. Yes, it's special and it's for you. The first thing that you need to do And with this one, it's actually I'm going to save you money. Ready? The first thing that you need to be doing is making sure that you go to your house, you check all that papitas, all the chips that you have there, all that soda that you have there, and the hidden dulces, the hidden sweets that you have, and try to take them out of the house. That's the first. That's the dieta del Dr. Shapiro. It's not vegan, it's not vegetarian, it's not Mediterranean, but it's actually making sure that the place that we live is conducive to being healthier. Why, familia? Because you're not going to let me lie. When we see that beautiful sweet, that chocolatito, we know where it's going to end up. And, if it's a Saturday, a Sunday, or we are very happy or very sad, we end up having those relationships with the food that we eat, and we end up not having that little vocecita, that little voice in our brain. Sometimes it's not there, and we just grab it, and it's something automatic. It's a habit. Then we need to make sure that we are at that moment pulling out and making sure that for us and for our children, it's an easier transition. It's a better way to have a conversation, a better way to be healthy, a better way to have a home. The second one, make sure that you're moving. I do not want you to be like a Olympic runner. If you want to, that's awesome. If you want to run a marathon, that's even better. But it's very difficult, and I'm going to try to do it here, to be laying in your house and going to your kid, like, mijo, go and run, and you have like a beautiful refreshment in your hand, and you're drinking it, and you're telling, go, 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 and do sports. Like, no, 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 family. Here, we actually need to do it all together. And the kids actually do not learn that much on the way that we say things. They learn by example. Then, if you want to walk around, that's awesome. If you want to do a hike, that's awesome. If you just want to put a YouTube channel and hear music with your kids and dance to it, that's awesome. But let's do it together. That will be awesome for us, because we all have 2 or 3 jobs. We're running from one side to another. We're doing a lot of things. There's pressure with the partner, economics, a lot of things. But who doesn't have 10 minutes to dance with their kids? It's something possible that we can do. And it's relaxing, and it's fun, and you can choose different music. My favorite, by the way, is La Bamba. That's the one that I do with my kids. That's the one that I do. And they put other stuff, and I try to be trendy, and I think my trendiness ended up in 2005. But that will be another topic. And the third one is making sure that we're sleeping. Yes, sleeping is completely underrated. Your grandma actually was completely right. At the moment that we sleep, we grow, and not necessarily us as adults, but for our kids. That's one. The other things that actually do is that the memory starts actually to solidify. It's actually starting to connect there. It starts actually to being better. Your immune system renews. Then sleeping better, it's amazing. Then you need to have a healthy routine. It's kind of landing an airplane, making sure that you're taking away any type of screen, making sure that you're not drinking that much coffee, making sure that you're enjoying reading, meditating before going to sleep, and you land sleep. A lot of the times, if we don't sleep well, we're going to do a lot of misbehaving with food, because the front part of our brain is already tired. Then when you see that papitas, that chips, or the soda, and all these things in front of you, you will not think twice. You're going to grab it and put it in your mouth. The same thing with other stuff, because you're going to start drinking more soda because it has a lot of sugar and caffeine, and you need to be awake. You, after that, switch to a lot of caffeine. A little of caffeine, it's awesome. A lot of caffeine could be problematic because you start this cycle. then familia with the 3 pillars of eating on the healthier side, making sure that we're moving as a familia, and making sure that we're sleeping actually can make a huge difference. The moment that we see our food, it needs to be, food is actually made for us to have fun. And the second part that is extremely important also, and by the way, is the most important one, is to give us nourishment. Then it needs to be not like grabbing your cell phone and eating all this stuff like this. You need to be on the moment present. And I have seen Dr. Angie actually talk about this, where you need to be mindful at the moment that you are eating. If not, it's like something automatic, and you're not having that relationship. And also, you eat faster, you're probably going to end up eating more, and probably not the best choices. Then if you're tasting it, feeling it, is it cold? Is it warm? That actually gives your brain more time to understand that if you're full, if you're hungry, and also a better relationship with food. Because you're not, everybody has a different relationship with food. And some of us actually use it to just, I'm happy, let's have this. I'm sad, let's have this. It's Christmas, let's have this. Then we have a very interesting relationship with food because it brings a lot of sentiments, a lot of memories, a lot of things. That's why we need to combine all of these things to make sure that we are moving forward for wellness. We are moving forward for changing the way that we're seeing our life. It's not about the number on the scale. It's about the quality of life that we have. It's the way that our children are having fun at school, that they are running, that they are happier, they are looking for joy. And us as parents and family members, we're a crucial component to get there. With this, remember La Dieta del Dr. Shapiro, remember the Dr. Shapiro diet. Make sure that you're moving with your children, with your family members. Make sure that you're taking care of your sleep. That way, with a mindful point of view, we can all get together, because with this, you're not just fighting, that thing or problems with weight. No. You're also fighting against diabetes, high blood pressure, depression, anxiety, and even cancer. This way, you can be part of this conversation. Then I'm giving away this microphone, and I am very thankful for the opportunity. And thank you so much. Y un abrazo, familia, and we will be here.
Gracias. Next slide, Allison, please. Let's see. Okay, great. Awesome by everybody so far. I want to finish us off before we get to the cooking demo by sharing a real world example. We've done a great job of understanding the pathophysiological aspect of gestational diabetes and of healthy eating and pregnancy and beyond, and of understanding Dr. Shapiro and Emma, Dr. Olivera, incredible examples of how to deliver messages and how to conceptualize all that. I want to anchor the team by sharing a real world example that we did at the hospital where I currently work. So I work at Texas Health Hughley Outpatient Diabetes and Nutrition Center. So I have my PhD in nutrition, but I'm a registered dietitian, but also a diabetes educator. And oftentimes we can talk so much about nutrition, but nutrition is still so underrated. Even me as a dietitian, I sometimes fail to really grasp the impact of someone's dietary habits, right, or what they eat on their glycemic control. So what we did was we actually received a grant from Advent Health, because our hospital is an Advent Health hospital system hospital. And it was a grant that covered unlimited diabetes education visits for moms who had gestational diabetes, who didn't have insurance, or who had Medicaid and weren't covered traditionally for our visits. And so the control group was standard OB visits plus maternal fetal medicine as needed. And then our intervention was that standard control plus 2 hours of diabetes education and nutrition education within 10 days of initial diagnosis, followed by as many visits as needed. And it was all covered by the grant. And I know this isn't feasible for every hospital. It's very difficult, but I'll talk about key takeaways and what we learned. In terms of the population, as you can imagine, all lower socioeconomic status, mostly Latinas, and split between 50-50 Latinas that were from Mexico mostly, and the rest that were Chicanas from here in the United States. And by providing the compassionate education, the culturally tailored education, and by helping ease the burden from our OBs and maternal fetal medicine specialists, we actually saw a 10% reduction in NICU admission, reduction in hypoglycemia at birth, reduction in macrosomia, reduction in shoulder dystocia, and all of those outcomes that we're trying to improve upon. And next slide, please. Other direction. Yeah, there we go. Thank you. The big question becomes, why did we see improvement? And here are the lessons learned. Number one, having rapid referrals is one of the most important things in all of healthcare, but also one of the most challenging things, right? We would all love to get our patients into an endo within a week, but we're probably short on endos, and even more short on endos that speak Spanish. But that being said, what was helpful for us was that we had a nurse navigator that acted as a monitor. Anytime gestational diabetes came up on her screen and saw that she was Medicaid or uninsured, she immediately contacted the patient and forwarded the information to us. So rapid referrals are very important. A major thing in our cultura is desidia, especially desidia hacia la diabetes. Oh, pues tengo el azúcar, pero ahí después me la cuido. We have to respectfully, right, bring the patients to really understand the importance of diabetes and also understand that it doesn't have to be something that scary. So it's that balance, right? A lot of patients are too scared and you have to bring them down to normalcy again. And a lot of patients are too dismissive. So read the room there. We have Spanish-speaking dietitians that helped, of course, and we had the translation machine there, the interpreter. But here are the most important takeaways. Why did we see these benefits? Number one is the fact that we really coach the patients on monitoring their glycemic response relative to what they ate. Because so many patients attend and they think, oh, pues ya no más tortillas, ya no más tacos, ya no más taquis. But what's fascinating is that sometimes tortillas don't spike their blood sugar very much, but elote does. And I encourage them that this is a journey of experience and understanding your own body. I'm not here to tell you, no vas a comer esto, no vas a comer esto. I'm here alongside with you, simply kind of like Dr. Oliveira said, almost like a mechanic reading the check engine light. Sometimes the check engine light, aka blood sugar over 140 to 120 after 2 hours, depending on the measurement that you use. I'm simply here to tell you the check engine light comes on when you eat this amount of food and when we're this inactive. And that takes the pressure, talking about the coche, talking about that takes the pressure off the patient. And so just kind of a rundown in terms of what you should look for. You should look for places to refer to that are going to discuss cultural foods with your patients. Ah, no sabía que frijoles me subían el azúcar. Pues no estoy diciendo que los frijoles son malos, pero hay que cuidar las porciones y hay que comparar cómo respondemos con diferentes comidas. Carb counting, depending on the health literacy of the patient. For some patients, I say un puño, dos puños. For others, especially for the younger ones, it's you can use MyFitnessPal. You can use whatever. You're not on a diet. You're simply learning. And you're simply trying to do what's best for you and your baby long term. And then the most important part, I always jokingly say that I got my PhD in nutrition so I could tell people what they could find at the dollar store and also at Whole Foods and everything in between. And that's what I would encourage all of us here as clinicians to be able to do, is have a little cheat sheet of when your patients ask you, pues, what's a good substitution for this? What protein bars do you eat? What do you eat for dinner? What did you have for dinner last night? You don't always have to be perfect, but patients are always simply looking, ¿qué es algo que puedo hacer ahorita? ¿Y qué hace usted? And maybe we could humble ourselves, and if we go to these fancy stores, visit the Dollar General where your patients go. Or if you have, or maybe you go to Costco or Sam's or wherever, visit the fancier stores if that's what your population is. Most of us in the Latino communities would really benefit, however, going to these dollar stores, el supermercado, fiesta, and even if you want on weekends, and trust me, I learned this from my mom. She has her PhD in nutrition in a different way from being a lower socioeconomic status mom with kids. She has her PhD in life and making ends meet. Maybe ask your friends and familia, hey, ¿a dónde vas a la tienda? Because to us, $6 for raspberries is nothing, but to a patient, you tell them to buy $6 worth of fruit. That's a ton of money. All right, I'll move right along so we don't finish too late. So we cover all that with the patients. We get specific on meal planning, and we actually do collaborative meal planning where after we've gone through the information, the patient gets to go through during those 2 hours, and they make a meal plan when we guide them through that. And then we'd follow them weekly or bi-weekly. And the last couple things to make sure we address it, we have free CGM or continuous glucose monitor samples. That technology is so powerful, especially for lower literacy patients. ¿Cómo vamos en la montaña rusa? ¿Son montañas o son cerritos? Queremos cerritos de 95 en ayunas, 140 o menos en 1 hora después de comer, y 120 para abajo después de 2 horas de comer. It's incredible how powerful of a teaching tool that is. And if you can get samples, be it Libre, be it Dexcom, and I'm not affiliated with any of those companies, how powerful of a tool that can be. And at the ADA conference, they actually talked about the importance of tighter glycemic control, the importance of CGMs. And lastly, the consideration for insulin. There's a lot of insulin resistance, right? In terms of pushback from our patients against insulin. But if the patient would benefit from it, it's our job to provide the standard of care. And slowly but surely, if you get one patient to do well on insulin, you'll get 20 or 30 within the community over the next few years as we normalize it. And lastly, compasión and being culturally understanding. Sessions like this are helping us understand. Just being compassionate and having empathy for where your patients are coming from. The last story I'll conclude with was I had a little boy who came with his mom to the gestational diabetes education visits. And we had this food model, like this cabinet full of food models, and I would let him play with it. I told him that's $1,000 worth of food models, so just be careful with it. But he had fun, and he played with the pizza, the chicken nuggets. And months later, when his mom gave birth to a perfectly healthy little girl, we went upstairs and greeted her. And as soon as I walked in the room, that little boy who hadn't seen me in a while goes, "Pizza, pizza, tráeme la pizza." He was talking about the little plastic food models. And stories like that are what make our jobs worth it, that we're leaving an impact on the moms, on the children, on the next generation, hopefully normalizing nutrition and normalizing exercise as everybody here has talked about. Next slide. Yeah. And just briefly here, know the determinants of health of the moms. One of the biggest things we learn is some of your moms are going to be working overnight shift, especially in lower income communities. Some of them work in very dangerous overnight shifts, such as in gas stations. In terms of socioeconomic status, understanding that. Social support. Don't get me started on machismo. That's what my dissertation was on. Understanding, does the mom feel supported? Does she have support? Is she divorced? Does she have support from her family? She might be married, but does she have support from her marido? Or does she have to wake up at 2 a.m. and make lonche? All of these are questions of support that we need to understand and build bridges with our patients. And the most important thing with all this is find resources. If the mom is stressed, she's never going to be able to make the changes. Find therapists, find free food pantries, help connect them with WIC. All of these things are important. And next slide, please. And I think we've already summarized what to do with moms, with pregnant moms, early childhood. Everybody else talked about that. So with that, I'm going to pass it on so that we can watch to conclude an awesome cooking demonstration by our leader, Dr. Angie Neeson.
So today we are learning about the foundation of the Latino health home, which is las mamás, the mothers. And so from then, the foundation we also need to take account is our vegetables and fruit. So again, this is the My Plate. We don't typically eat this way, but as you can see, there's a more emphasis on the vegetables than the fruit. And then one thing I want everybody to take in mind is a child's plate is a lot smaller than an adult plate. Vegetables and fruits as half of the plate, more emphasis on the vegetables than the fruits. My favorite tricks is to use a red onion. So one easy trick you can do in order for you not to have your kids cry when they're cutting the onion is to put this in the freezer, and then you can slice it. And again, when we're learning some chopping skills, again, remember you hold the knife. This little nod right here is for the middle finger, and then you grasp the knife this way. Your other hand is like a claw, and your knife is supposed to hit the back of the hand so that you don't splay your fingers and cut your fingers. So safety first, and you just slice the onion. You can also use kid gloves. So the kids can wear these if you were afraid of them around the knife. They can wear these, and you can get these on Amazon. Again, I always recommend having tools in the kitchen that you can help your kids be in the kitchen with you. And then one of my favorite things you can do to make sure that the onion has a better flavor, better taste without so much of the bite and so much of the onion flavor is to get an ice bath and throw the onion in here and leave it soaking for about 10 minutes. And then you can throw this on sandwiches, and it still retains the flavor, but it doesn't have so much of that powerful, pungent onion taste that kids may not like. Okay, and now I have my son Elliot, who's going to show you how we cut our mango. So one of our favorite fruits for the summer and pretty much all year round is a mango. I like throwing this in salads or smoothies because I can get my kids to eat more fruits and vegetables or a salad if it has mango in it. So when you get the mango, here is the seed. You cut it on the sides of it. So go ahead and slice it. You get one side, and then you get the other side. And then my son Elliot's going to show us his favorite trick to get the most out of the mango. So you slide the mango along the side of the cup, and all the mango falls in with the juice, so you get to make less of a mess and also get the most of the mango. Clean skin. Once you get all the mango in, you can slice it. Another way to cut the mango is to slice it, and then you make a crisscross pattern, like a tic-tac-toe pattern. And this is called a turtle. And you can serve it like this on top for a kid's after-school snack, and they can get it with a fork. If you want it sliced like this, you could also slide it against the cup, and you get cubed mango ready to go. Again, as a family doctor, I encourage all my families to try to enjoy being together in the kitchen and connecting together. So giving the kids the tools. So this is a garlic press. It gets rid of the skin around it. So again, these are little stocking stuffers or little gifts that you can give for their birthday, but have the kids just roll it through like this. Easier to peel the skin off. That. Okay, it's ready. There we go. And so as you can see, these become sort of your meal prep helpers. And then after you get all of your garlic pressed, you can use this garlic twister. And you have the kids. Yep. And now you have crushed garlic. is using an herb that they like to put in a salad. So we grow mint because it is very plentiful and easy to grow. It's a weed. And so what I get little kids to do is to just pick off all the leaves.
It doesn't grow in your garden.
And grows in your garden. And so we pick up all the little leaves, and that could be something a little kid can do. You know, think of a toddler. And this will keep them entertained for a little bit while you're in the kitchen and you're cooking the rest of the food. The other thing you can do is you can grab the sprig and then just clean it like that. That also works too. And if you want to combine the mint with some other different types of greens, I recommend also just combining them. You can chop them up finely, but have the kids try this. This is a peppery type of green, which I find that my kids like more because it has a little bit of flavor. So again, you can just rip them apart and then combine it, and it's all mixed in with the green. And so you've just added a nice bit of the salad. Okay. So now that we have our greens in a salad bowl, we're gonna have added fat to absorb the nutrients. So we're gonna add about 1/4 cup of extra virgin olive oil. You can use canola oil, you can use avocado oil if you want as well. Okay, you just add that all in there. Okay, and have you mix it. We're gonna add a little bit of the garlic in there. We're gonna add the mango. And then lastly, we're gonna add a little bit of the red onions to make it colorful, and this brings out all of the flavors together. You can add chickpeas, you can add black beans to this, protein, anything that you would like to add on top of this, but this is a good base and a good foundation for a salad. Next, I'm gonna top it with an avocado. Again, healthy fat, fiber, which is another reason why I love avocados, is that it keeps my kids full. Okay. And then the very last thing is I always ask kids, come taste it, tell me what it needs. And usually it needs a little bit of acid, and so I have them put a little bit of vinegar, or they can add fresh lime, fresh lemon, and they can help you squeeze it in and mix it up. And then I have them taste it again. I'll say, what else does it need? Usually it's a little bit of a pinch of salt, and so I'll have the kids put a little pinch of salt in there. Okay, a little more. And even if they don't taste or have the salad, at least they have given an opportunity to place the foundation of a very strong, healthy meal in front of them and helped you make it. One of the most typical questions I get from families is, are frozen fruits or vegetables just as good? And I always say yes, they are perfectly fine. They are picked right at peak season, so they actually contain more nutrients than you would if you were to get it at the store. So I definitely recommend, these are an investment, what I call your vitamin investment in your freezer. So take them out, use them. Canned are perfectly fine as well, just trying to remove the extra syrup that contains a lot of sugar. One of the fun things I love to teach is to make ice cream out of frozen fruit and a ripe banana. So all you do is just peel the banana, let the frozen fruit thaw out a little bit, and you mash it together. And you can use a an immersion blender like this, or you can use the blender, or you can use a fork. As a smoothie, you can make popsicles out of it. You could also portion it out into small little containers that are ready to go, so that when dinner is over, or if they want a fun snack, they can have some berry ice cream ready to go. And just 2 ingredients. Fiber-filled, foundational, sweet, and wholesome.
Well, that was wonderful. Gosh, that looks delicious. Thank you so much, everyone, for joining today. We want to thank our speakers again, Dr. Antonio Miranda, Dr. Emma Oliveira, Dr. Erica Montes, and Dr. Elon Shapiro. And of course, thanks to Dr. Angie Romero Neeson for that wonderful cooking demonstration and for putting this series together. Don't forget to sign up for our next 2 sessions, July 26th and August 2nd. You can sign up at the San Bernardino County Medical Society website, sbcms.org, under our events. And you can register for a CME here today, as well as watch the recording and watch recordings from past sessions if you like. We'll be sending out that information to you. Thanks, everybody. Have a great weekend, and we'll see you in a couple of weeks. Bye-bye.